Hello, good morning, all of you. Now, this is the second video regarding the questions which we were discussing that have come in FMG December 2019. Now, we've already discussed three questions. Now, these are the second series of three questions which I'll be discussing today with you. Let's see the questions. Now, this is the question which you've got, and in this, the question says patient CBC report shows MCV less than 80 femtoliters and MCH less than 20 picograms. What is the type of anemia the patient is suffering from? Okay, the options are there on your screen: microcytic hypochromic, macrocytic hypochromic, microcytic normochromic, or normocytic normochromic. Now see, this is obviously by the options also we understand, and in the question also the examiner has asked you what type of anemia the patient is suffering from. Now, if we talk about the types of anemia, guys, types of anemia, okay, broadly if I say there are three types. First, which is hypoproliferative. Hypoproliferative. Second is hemolytic. Second is hemolytic. And third type of anemia is due to chronic blood loss. Or even if this blood loss can be acute also. Chronic or acute blood losses. They can give us anemia. What is anemia? Decrease in the hemoglobin concentration or decrease in the RBC mass on the basis of age, gender, and geographical location. So whenever the RBC concentration or the hemoglobin concentration is low, we call it as anemia. Now, for any kind of anemia, let's say we are talking about hypoproliferative. Now, what is hypoproliferative anemia? Proliferation means division. Hypo means less. So that means there is less division happening where? In the bone marrow, the factory which is making the blood, which is making the RBC. So when the hematopoietic stem cell inside the bone marrow is dividing slowly, therefore the final product, that is an RBC in the blood, is coming less. So the RBC mass will be low. If the RBC mass will be low, obviously it will be called as anemia. Again, hemolytic. Hemolytic anemia means hemolysis. Hemolysis means destruction of the RBC. So the bone marrow is fine, the factory is working fine, but when this RBC comes inside the peripheral blood into the vessels, the RBC is being lysed, is being destructed somehow. That is hemolytic anemia. And chronic blood loss and acute blood loss, these words already tells us that if a patient is having a blood loss for a very long duration, or suddenly the patient is having a huge blood loss, then obviously the RBC mass is going to be low and the patient will suffer from anemia. Now in this patient, see, we are talking about anemia, so we are talking about RBCs. We're talking about RBCs. Now see this peripheral blood smear here. In this peripheral blood smear, the blood smear A, you are seeing these RBCs and WBCs in that. And these cells, this is an RBC. And these cells here, these are WBCs. We are only concerned about the RBC right now because we are talking about anemias. Whenever you see an RBC, see what the RBC looks like. It has got the central pallor, the central area which is a little light in shade. Okay, so a normal RBC, we know it is a biconcave shape or dumbbell shape, biconcave or double shape, and these RBCs which we are talking about, they are having a central 1/3 pallor. So there is a central 1/3 pallor. There's a central 1/3 pallor. Okay, guys. So see, and the size is 7 to 8 microns. Size is 7 to 8 microns. Okay. Now the value, what is MCH and what is MCV? Now MCV means mean corpuscular volume. What it does mean? Mean corpuscular volume. And mean corpuscular volume means that volume of a single RBC in the blood. Okay. The normal value of this MCV this MCV, the normal value is from 80 to 100 femtoliters. 80 to 100. So if in the question the examiner is saying that the volume is going less, that means RBC is becoming smaller, right? Now when the RBC is becoming smaller, and the second thing was MCH, that is mean corpuscular hemoglobin, but the hemoglobin is also going low. Okay, hemoglobin is also going low. What is MCH? Hemoglobin concentration in the RBC. So the normal MCH, if we talk about normal MCH, it is from 27 to 32 picograms. Now see the value in the question. The value is less than 20 grams. That means hemoglobin content is also low. Okay. So if I make an RBC like this, or let's see in the figure. Now this was the RBC which you're seeing in the figure. And in this figure, I'm saying that the RBC which you're seeing in figure A, these are the normal RBC. That means the size of these RBCs is 7 to 8 microns. The MCV in these RBCs is 80 to 100 femtoliters, right? And the hemoglobin MCH, if you talk about the MCH is 27 to 32 picograms. Now these are the values which I'm talking about figure A. Okay, now what is going to happen when the volume is going to go low? When the volume is going to go low, the RBC will become of a small size. So a small size, cell is a small, microcytic. Cyte means cell, micro means a small. When the volume is going low, the small size of the cell is becoming small, so we call it as microcytic. And when this RBC contains this hemoglobin, I'm making with this red color, this hemoglobin when it is normal, the value is 27 to 32 picograms. And hemoglobin gives color to the RBC. So chromasia means color. Now when in the question it is said that the normal color of the RBC, the normal hemoglobin of the RBC is going low, that means the color is going low. When the color is going low, that means it becomes hypochromic. Hypochromic, come color. So what will be the answer, correct answer for this question? The correct answer for this question will be microcytic hypochromic. The answer is microcytic hypochromic, and the most important anemia for microcytic hypochromic type is iron deficiency. And this is the picture which you can see for the iron deficiency anemia, this B type of picture. Now you can see that the RBCs have gone small. They're of various sizes, various shapes. So anisocytosis is there, which is size variation, and poikilocytosis is there, which is shape variation. And then you can see the color is getting less. You can see the central pallor in these RBCs are becoming very much high. For example, you see this RBC. This is the RBC, and see the amount of white color it has inside. So these RBCs are becoming small and they are losing the hemoglobin also. So whenever the MCV is low, MCH is low, that means the RBCs are going small and the color is also going less. So the type of anemia would be microcytic hypochromic. Let's see the second question. Which type of anemia is seen with vitamin B12 deficiency? Which type of anemia is seen with vitamin B12 deficiency? C, vitamin B12. Now this vitamin B12, first let's try to understand, then I'll come back to the question again. This vitamin B12, what is the need of this vitamin B12 in our body? The need of this vitamin B12, it is used for DNA synthesis and nuclear maturation. It is seen with it is used for DNA synthesis and nuclear maturation. Now, whenever we are talking about this DNA synthesis and nuclear maturation, basically, see, this is the bone marrow. Let's imagine this is the bone marrow, and here this is hematopoietic stem cell. It is taking multiple divisions, and then finally it is giving you a mature RBC. Now, this bone marrow needs vitamin B12 for maturation and DNA synthesis. Now, let's say this vitamin B12 is not present. If the vitamin B12 is not present, obviously what is going to be hampered inside the bone marrow? The cells inside the bone marrow, they will not be able to have a mature DNA. And even the nuclear maturation will be hampered. So DNA synthesis will be abnormal and nuclear maturation will be abnormal. We all know that this hematopoietic stem cell which is there inside the bone marrow has got a very big nucleus. And RBC is a non-nucleated cell, right? We know that RBC does not contain any nucleus, but the factory from which this RBC is coming up, all the cells of that factory contains a nucleus. That means that something is happening inside the bone marrow, that step by step the nucleus is going to go away. The nucleus is going to go away. That is why the RBC, the final product, does not contain the nucleus. And we all know that RBC is 7 to 8 micron size cell, whereas hematopoietic stem cell is a big cell. It's a stem cell, so it's a big cell. So what I can say that from up to down like this, there is two things. Maturation is increasing. That is why you are getting a very mature cell outside the bone marrow, and the size of the cells are decreasing. Hematopoietic stem cell is a very big cell and the RBC is a small cell. So if you are not giving B12 to these, if you're not giving the B12 to these, what will happen? The maturation will not happen. So what will be the product? What will be the thing you will see? That the maturation, because of absence of vitamin B12 inside the bone marrow, the maturation is going low. And the size also is not able to decrease properly, and eventually whatever cells you're going to see in the blood, they will be of big size, right? So big size cell, a big size cell means a cell matlab site, and big means macro. So megaloblastic anemia, beta, always remember it's a type of macrocytic anemia. Whenever the word macrocyte, macroovalocyte comes to your mind in front of you, you should be thinking about megaloblastic anemia. And what is megaloblastic anemia? It is an anemia due to vitamin B12 or B9 deficiency. So again, see the question. Which type of anemia is seen in vitamin B12 deficiency? Microcytic hypochromic? No. We know the cell size will increase, not decrease, right? Then normocytic anemia? No. The RBC will not be normal in size. They will be what? They will be more. So microcytic hypochromic or macrocytic hyperchromic anemia. So what will happen is that the answer would be macrocytes. You will have macrocytes in vitamin B12 deficiency. What other things you can get? See, this is a picture of macrocytic anemia, and you can see big cells here. This is in your RBC. See how big it has become. This is what? This is a lymphocyte, small lymphocyte. Now the size of an RBC is equal to a small lymphocyte. They're more or less same. See the size difference between a small lymphocyte and a large and an RBC. RBCs are big. That means they're become macrocytic. One more thing which is very important for a megaloblastic anemia is hypersegmented neutrophils. Now we all know that neutrophils, they are a WBC. They're the maximum in amount, and they contain 3 to 5 nuclear lobes. So whenever you are making a neutrophil like this, there will be a neutrophil, and neutrophil will have minimum 3 nuclear lobes, maximum 5 nuclear lobes. So these are the 3 nuclear lobes I have made: 1, 2, and 3. If they are till 5, it is a normal neutrophil. So whenever the neutrophil is having 3 to 5 nuclear lobes, you say that the maturation of this neutrophil inside the bone marrow has been good. But once you are getting more nucleus, that means the maturation process has not occurred properly. So you will have what? You will have more nuclear content, means more nuclear lobes. So hypersegmented neutrophil is, again, hypersegmented means any neutrophil containing more than 6 nuclear lobes, equal to or more than 6 nuclear lobes. See the nuclear lobes: 1, 2, 3, 4, 5, 6, 7, 8. So it has got, this is a neutrophil which is getting more nuclear lobes than 5. So it's an hypersegmented neutrophil. Again, a very important finding of megaloblastic anemia. And then this is a figure of 8 inside the RBC. This is called as Cabot ring. What do you call it as? Cabot ring. Figure of 8 inside the RBC. It is made up of microtubules. It is made up of microtubules. So it is a Cabot ring which you see in megaloblastic anemia. So big RBCs, hypersegmented neutrophils, Cabot ring, they're very important features of megaloblastic anemia. You can also see Howell-Jolly bodies and basophilic stippling in megaloblastic anemia. These are what? These are the cells, these are called as megaloblasts. They are what? They are megaloblasts, and they have salt and pepper chromatin, sieve-like chromatin. Okay, so this is a megaloblast which is having a salt pepper or mesh-like, sieve-like chromatin. See the chromatin material, dark red color thing inside them. So it is looking like there are gaps, there are pores in that. तो छलनी के अंदर जैसे gaps होते हैं, वैसा gap दिख रहा है इसके अंदर. So they are what? They are megaloblasts. Megaloblasts, which are having what kind of chromatin? Sieve-like chromatin. Sieve-like chromatin. Okay. Then the third and the last question for this today's discussion: gum hyperplasia is associated with type of leukemia. See, now this question is from the chapter leukemia, and leukemia is what you see the blast inside the bone marrow, inside the blood. So when the WBC blasts, they are inside the blood, in the peripheral blood. When you see them, it is called as leukemia, right? Now leukemia, as we all know, there are 4 types: acute lymphoid, acute myeloid, chronic lymphoid, chronic myeloid leukemia. So all the 4 options are given. Now the correct answer for this question is going to be AML. What is the answer? AML. Now how to get into this? See, beta, there are 2 kinds of acute leukemias will have this. So we get confused between ALL and AML. Now I'll be telling you some points about the differentiation between ALL and AML. See, how I have learned it, that if the examiner is asking you any kind of central involvement, for example, CNS involvement, mediastinal involvement, testicular involvement. So all those type of involvements you will talk about ALL. अगर बीच में है, center में है, तो ALL. Gum goes to the periphery. Gum goes to the periphery. So this peripheral is AML. Peripheral is AML, and anything central is ALL. This is how I've learned it. Okay. So because in this they're asking gum hyperplasia, then the answer for this will be acute leukemia. So you are gonna, what is acute leukemia? You're gonna see more than 20% blast in the blood. Okay. So we are talking about acute leukemia. In this, what you're gonna get, more than 20% blasts in blood or bone marrow. Right, guys? More than 20% blast in blood and bone marrow. This is what you're gonna get in this. And in acute leukemias, and it can be of 2 types, ALL and AML. ALL and AML. And this, I told you, anything which is central involvement, most probably that would be ALL. And gum goes to the periphery. This is how I've learned it. It is AML. Now, could be more leading question, that which kind of AML. So for that, you should be remembering that how many types of ALL are there. See, there are 2 classifications of acute leukemias. One is FAB classification, and other is WHO classification. FAB is a classification which is not very fondly used for ALL right now, but for AML it is still widely accepted. And I will be telling you that in today's discussion, the FAB classification. FAB classification. FAB classification is what? French, American, British. So the 3 people, they came together and made a classification: French, American, British, FAB classification. According to this classification, this FAB people, they divided AML into 8 types. 8 types. Okay. Now it is from M0, then M1, then M2, M3, M4, M5, M6, and M7. So there are these 8 types of AML. The counting goes till 7, but it starts with M0. Now, if the next leading question could be that what is the type of AML with which the gum hyperplasia is most common? So it is M5. M5 is the type of AML with which the gum hyperplasia will be more common. And with AML, I would like to mention one more point, that when you are seeing AML beta, there is a very important cell which you see in AML, and that is called as OR rods. Okay, so see, this is the picture of OR rods. What is OR rods? This is a blast, a big cell, a blast, a myeloblast, in which you are seeing what? You are seeing these tubular projections, cylindrical projections in the cytoplasm. Now these projections, they are basically, this kind of a blast is called as OR rods, or blast containing OR rods. Now this is a characteristic feature of AML. What is it? It is OR rod, OR rods containing blast. And this is a characteristic feature of AML. Okay. Now, because it's a characteristic feature of AML, so examiner, if examiner says you are finding or rod, so directly you go to this kind of picture in which you are seeing or rod, it cannot be anything else than AML. But again, a leading question can come to you that which type of AML out of these 8 types contains or rod most commonly, then it is M3. So M5 is for gum hyperplasia and M3 is most commonly for or rods. So this gives us all the explanation of 3 questions. Gum hyperplasia, you now know it is AML, which AML M5. Okay guys, thank you for your patience. I'll see you soon in the next video.